there, Dermot. So hello and welcome everybody. My name is Dr. Tony Cox. I'm with the ICGP, and Dr. Molly Owens, my colleague, is there as well. You probably know us from being over and back to meet you when we could meet you before COVID came to town. So this is the continuation of the successful webinar series, and we have a really good webinar again lined up today. I'm going to hand over shortly to our chair, Dr. Nada Albunian. Dr. Nada is the Academy Director in the Eastern Province, and the speaker today is Dr. Dermot Nolan, a good friend and colleague of ours in Ireland. He's the clinical lead for asthma. So I think I'll just hand over to you, Dr. Nada, and you're the chair for the day. And thank you very much for doing the job for us. And thank you, Dermot, for doing the webinar.
Thank you. Good evening, everybody. Welcome to the 9th webinar with the title of Bronchial Asthma. Dr. Dermot Nolan is a presenter. He's a full-time GB in Tramore, a GB trainer also on the Southeast GB scheme. He's volunteering his time to give us a speech about bronchial asthma and the update. Thank you very much, Dr. Dermot. The mic is yours.
So thank you very much, Nada, and thank you, Tony, and thank you everybody for joining in today. And I know the title of the talk was Bronchial Asthma, but I've fooled you all and I've got you to dial in because it's such a big topic. I decided to shrink it down and bring it into pediatric asthma, and then that's even quite a big topic. So I thought I'd bring it into preschool asthma, because it's an area that we see quite a bit of, and it can be slightly tricky to manage in practice. So I decided that I think it would be a good, useful talk. I did do a talk about 2 weeks ago to the GP training, or to the family practice training scheme, about asthma, which I think may be available if you want to watch that also. But this would be, we're going to focus on the young asthmatic child. And I say, so I'm Dermot Nolan, I am the National Clinical Lead for Asthma. And I developed an interest in asthma for a family reason. My own brother, who was a year younger than me, was very poor asthmatic as a child and was never diagnosed. He was always considered slightly weak or not good at sport. And when he got treatment a little bit in his teenage years, his life transformed. And that one of the reasons why I decided to medicine and why I decided to get a focus on respiratory medicine. So this is going to try to bring in some aspects of the young asthmatic child into your day-to-day practice. Can I just get the next slide? Apologies here, guys. So some of the reading and where we've taken some of the data from for this talk is our guidelines are based on the GINA guidelines, which is on the website gina.org, which is the global initiative for asthma. I'm not going to say a lot about adult asthma, but it is important maybe people would have a look at the new GINA guidelines, because the bottom line is, if you have asthma, you need to be on inhaled corticosteroids, not puffing away on a blue inhaler all the time. That's the key message. I'm not going to say anything else about it, but it is worth having a look at it. I also took some of this talk and some of the from the Saudi Thoracic Society, which have really excellent guidelines published online, edited by a guy called Andy Bush, who I worked with in the UK at one stage, and also have used the ICGP clinical guidelines. So there's where some of this information has come from, and it's readily available. So this is where I work. This is at my hometown. This is Tramore in Ireland.
Dermot, can I interrupt you for a second? I'm so sorry. We're not seeing your slides there.
Oh, sorry.
Sorry.
Oh, sorry. What would that be?
It'd be a shame not to see now your hometown, you know. Not
apologies. Share screen. Sorry. Is that working now?
No, it isn't open yet.
Just put it in slideshow mode.
Just put it in slideshow mode for us, yeah.
Apologies about this, guys. Okay,
there
are we go. There?
Now
is it working?
Yeah, that's it. Perfect. Very much. Thanks.
Okay, thank you, Molly, for that. So this is, again, my hometown. It's a seaside resort down the southeast of Ireland. And this year was quite a good year for tourism because no one could travel, so we had a lot of tourists. So so again, I would hope that maybe when we start to travel again, I would love maybe if any of the doctors would like to come and visit us, we'd be more than love to have you down in our to see our clinic. And I was talking to Victoria beforehand. I said today it's about 14 or 15 degrees and a little bit rainy and cloudy. And she said, oh, I wish I had that. We wish we had that because it's very hot where you are. So this is some of the beautiful beaches in your home country, which I'm sure is also very beautiful. So I thought that image was quite nice. So I'm going to talk a little bit about the background of asthma. And asthma is the commonest chronic childhood illness that we deal with. So family practice manages in this country, and it is different, and in the UK, about 90% of the asthma is managed solely by the family physicians. And I always think that asthma is a very good condition. It sums up everything that we need in family medicine. It's a lifelong condition. There's no special tests or high-tech investigations required. It requires education, monitoring, and all the stuff that we do in day-to-day practice. It affects all age groups, all socioeconomic groups. And when you treat it properly and when you look after these patients, they will become your friends for life. And in Saudi Arabia, this is from the studies showing that it affects between 8 to 25% of children. And that's sort of what roughly the same as around the world. In Australia, New Zealand, Ireland and England, we have quite high rates of asthma. Probably we're not exactly sure why that is. It may be partially genetic, partially environmentally. There's lots of different theories about it, including the theory that our children are not getting dirty enough. They're not playing outside in muck and sand and clay, etc. And their immune systems are remaining immature, so they're overreacting to normal things they shouldn't be reacting to. And this is why we feel the so-called hygiene hypothesis, is why that rates of asthma have increased. And also probably doctors are better at diagnosing it now. Now, the good news is that although it's increased, the increase has sort of leveled off for the last number of years. So hopefully we may be getting better at it. But when asthma affects children, what happens to them? They can't sleep, they can't play sport, and they miss school. In this neck of the woods, children with asthma miss on average between 10 to 14 days per school per year. So that's quite a lot of school missed. And if kids are sick, parents miss work. So that has an economic effect for the family and also for the country itself. So it's important that we look after this. And as I said, most of this can be managed by primary care physicians. And also, because we know that doctors' time is getting valuable, we're getting more busy, practice nurses and allied pharmacists and other allied healthcare professionals have an important role in helping us with this. So preschool asthma is sort of challenging. It's a little bit difficult, and it's one that sometimes people find hard to sort of get our heads around. There was a theory at one stage that you couldn't diagnose asthma in anybody under 5, and that sort of hung around for a few years. That probably has changed now, but why is it challenging? Because it's a variable condition. Some days good, some days bad. Some weeks good, some weeks bad. And this is the nature of asthma. We rely on parents telling an accurate story. So parents might not even be aware of what's happening themselves. They just put down that little Johnny can't play sport today, or he's tired, or there's a number of reasons. There are no accurate tests for asthma. So it's sort of, probably in this age group, you can probably start to think about tests when children are about 6. we run a very busy asthma clinic, and we're not able to do it on our 6-year-olds. We can do it roughly about 8 or 9 is when I feel it can start. But in some of the better centres and some of the hospitals, they can do spirometry from about the age of 6 onwards. But it is difficult and takes a lot of expertise. And time is important for this. This is not one where you make the diagnosis. That's it. You move on. We use time as a sort of almost to help us with the diagnosis. So we either give them no treatment and see how they go, or we give them treatment and see how they go. And we're using our skills as clinicians to look at these patients. So what I want you to consider is, how can we diagnose an asthma in the under 5s? What should we look for in the history? What examinations should we perform? And is there a role for tests? So that's what I'm going to sort of try and focus on today, to try and make your busy lives a little bit easier. And this is a typical scenario. This is 3-year-old Hamid. He comes in and tells us that he's been wheezing for 2 days. No temperature, no stomach upset, no GI upset, no rash. He's feeding well. He's had no family history of asthma. He's no atopy, so he's no eczema or hay fever, and has had no previous episodes of this. And sometimes, and I'll just put this mum in, sometimes when parents come in, and what they are hoping is, I hope he doesn't have asthma. And because in the population, sometimes there can be a perception that asthma is, a very bad thing to have. And I think it's important that we, not so much maybe in this case, but in all cases, that we think of the parents and what they think was going on, because you need to tell them that some of the top Olympic athletes have asthma, some of the best sports people, business people. It doesn't necessarily mean that the child is weak or is going to have it. If it's treated properly, it will not impact on their life. But if it's not treated properly, it will have an impact on their life. So that's sometimes I always bear that in mind when you're dealing with parents. So when you examine little Hamid, he's alert, he's smiling, hydration and nutrition are normal, no temperature. ENT examination, so is a mild, nil, there's nothing to find, no pus, slightly red throat, and a few lymph nodes in his neck. And when you listen to his chest, a mild expiratory wheeze. So this is not an uncommon scenario that we're talking about. And this, so in the young children, this is what we have to go through in our brains to think what's going on here. We're like mini detectives. We have to try and think to put the full story together. So typically, and this is what we need to look at, because there is a little bit, medicine is an art. It's not a science, and sometimes people forget that. This is what we call the art of medicine, where you need to try to put everything together. But these are what you need to think of. So typically, there's a history of multiple attacks of shortness of breath or wheezing in a season. So one winter or one summer, he gets 3 wheezing attacks. That's likely, think about it. Coughing, and usually the cough lasts for 2 weeks. It interrupts their sleep, and it's not related to an URTI. And it is interesting that we used to diagnose a lot of cough asthma where they only had the cough, but they didn't have the wheeze or any other features. And for many years, we diagnosed this cough asthma. But now the modern thinking is that is not really very, very common. It's a very, very rare phenomenon of cough asthma. And most of this chronic cough that we may have put down for cough, put down as asthma, is probably not asthma. It's just post-viral cough, but not to label it as cough asthma. On exam, when you listen to the chest, you get this equal on both sides, a diffuse expiratory wheeze, particularly say on forced expiration. I'll often look at the nose to check is there any signs of polyps or rhinitis, and then we look for things like other atopic features like eczema in their flexures, and things like asking about food sensitizations, peanut allergies, other allergies, or sort of point you in the direction this is an atopic child. You need to ask about and I find this very useful. Family history is really important. So if little Hamid comes in and he says his two older sisters have asthma, your ears are, you're thinking, could this be asthma? And it's interesting that asthma seems to follow the maternal line more than the paternal line. So if the mum has asthma, that's a stronger indicator of asthma, although the dad is important also. As I said, you're listening to the breath sounds. And then we often use a thing called a therapeutic trial. And this is very, very important. This is where these children come in, you give them and I will see these kids, if I'm thinking, could this be asthma? So I'll often put them on a trial of beclomethasone, 50 micrograms twice a day, 1 puff in the morning, 1 puff in the evening. And I send them off and I tell them, I want to see you again in 8 weeks' time. When they come back in 8 weeks' time, the parents will sometimes say, he's much better. He's not coughing at night time. He's able to do things. But what you need to do with the therapeutic trial is you need to stop the medication there. You say, okay, we gave him a trial because this child might have got better if we did nothing. So this is why the therapeutic trial is important. 8 weeks of the treatment, even if they improve, you just don't say, well, that's just asthma, keep on going. You stop it and you say, see how he gets on. So if he stops it and he comes back after 2 weeks, oh, doctor, his cough is back again, then that's the trial positive, and you restart them, and that's your therapeutic trial. But if they come back to you and they say, listen, he's still perfect off the medication, it probably wasn't asthma. And why I find this is very useful is that it teaches parents the importance of compliance at a very early in the diagnosis. They remember, that when we stopped his inhaler, he got wheezy again, or he got very bad. So it's important that a therapeutic trial is done properly. I talked about spirometry. We talk about it's not children over 6, maybe, and where you can give them see is there reversibility. That can be done. In our clinic, we do it over the age of 8, but it can be done in under 6 if you have a very good technician. Chest x-ray, I don't think I've done a chest x-ray in a child like this in the last 10 years. You're just exposing them to radiation. You rarely, if ever, need it, unless you're thinking about an unwell child with a pneumonia or something like that. Tests for hypersensitization, skin prick tests, IgE blood testing, not really necessary. I don't think they're, unless you think something like a peanut allergy or something else you want to check for, but you don't need to organize these tests. And this is a very famous saying in medicine: all that wheezes is not asthma. So if you remember nothing else about this talk, if you can remember that, just thinking it's not always asthma. And most wheezes are viral induced wheezes. And they spent a lot of time trying to divide these into those different phenotypes and, episodic and persistent. And basically it's a viral wheeze, and they make come and go. And these are not, and up to 40% of children will get viral wheezes, but they don't have asthma. And I'll talk about how you can distinguish that a little bit later on. So I say it's important to remember that most viral wheezes, and that's what our little patient, little Hamid, had through a viral wheeze. But you need to start thinking, could there be other causes of wheezing? And just, again, we are physicians, we need to start thinking of the bigger picture. Could it be a cardiac cause, cystic fibrosis, inhaled foreign bodies, reflux? And there's a big, long list of things. But just in the back of your mind, thinking, could there be something else going on with this? And back to our detective role, we always need to keep a clinical suspicion. So, the things these are what we call mimics that might wheeze, but you want to just be very careful of this age group and thinking, could there be something else going on? And so these are not features of asthma. So if a child looks miserable or is a failure to thrive infant, suspicious. Onset of wheezing are very young, like between 1 and 3 months, not typical of asthma. Vomiting associated with respiratory, not typical. Continuous wheezing. Children with asthma, even young, don't continuously wheeze. They wheeze episodically. That's the way asthma works. Failure to respond to asthma medications. Then things like clubbing or focal auscultation signs we might hear. Again, it's, and symptoms that are not associated with typical triggers. So cough when they lie down or something a little bit bizarre. You need to keep your detective hat that something else may be going on. And there is this, in the Saudi guidelines, there is this called the Modified Asthma Predictive Index. This is a little thing you can think of, and I find this useful. I'm sort of doing it with my patients as if it's negative. So, and this is, if you see a child with on this fourth time back to you with a wheeze, you can sort of use this as a good parameter to see if it's asthma or not. And if they have one of the major criteria, so that's a parental history of asthma, particularly a mother, if they're skin positive to aeroallergens, even though we don't do that test very much, or if they have eczema, physician-diagnosed atopic dermatitis, if they have one of those, there's a very good chance that these kids will go on to have asthma. Or if they have two of the other minor criteria, such as eosinophil count greater than 4%, and I'm not recommending you do blood counts on these tests, but sometimes these children may have had blood tests for something else. And if you just, it's worth having a little look at the eosinophil count. It gives you an idea that there's something allergic going on. If they're getting wheezing unrelated to colds or sniffles, and if they have allergic sensitization to milk, egg, or peanuts. And if, however, they have none of these, there's a 95% chance of them growing out of it. So it's a useful thing to, and parents love to hear about their kids growing out of asthma. The reality is that if you have true asthma, you probably don't grow out of it. What you grow out of probably was never asthma in the first place. So that's important. So this little Hamid, I said, how would you treat him? And I think the options are do nothing. I think that's not unreasonable. Just tell them, listen, this is going to get better. You might consider a short-acting beta agonist trial to see does it improve symptoms. Not unreasonable. But the probably thing we probably did a lot of up to now, and now the recommendations, we don't give oral prednisolone steroids. They just they get quite, some of these kids can end up getting a lot of course of oral steroids, and it does have effect on growth, bone health later on in life. So outside of an emergency department, the guidelines are that we shouldn't be giving prednisolone to this age group. Most of these kids can take, if you tell the parents it'll get better in 2 or 3 days, they'll be back to you. But these can take 10 days to 2 weeks for that wheeze to disappear, but it will disappear in this little child's case. This is another, again, a slightly different scenario. Khalid is a 5-year-old boy the background is asthma diagnosed at the age of 2. He's had 1 admission to hospital in the past year. He's missed a good deal of school. His mum has asthma, his sister with asthma, and the dad smokes. So his medications is on beclomethasone, 50 micrograms BD. He's on salbutamol, 2 puffs QID PRN, and montelukast, 4 milligrams at nighttime. And he's in for review. And the first thing that would strike me is that he's had an admission. So an admission for asthma should be a very, very rare occurrence. That shouldn't be happening. So there's something not going right with this kid. And this is not an uncommon scenario. So you need to assess the situation. You need to look at what is his asthma control like, and we'll talk about that in a second. You need to look at what are the future risks of him ending up in hospital again. We need to look at, is the medication right? Very important, we need to look at compliance, the side effects of medication, is that an issue? Any non-pharma measures, so the dad smoking, that really needs to be looked at because that is one of the major triggers for pediatric asthma. And you need to talk to the parents. What's their view? And are they buying into this asthma thing, or what do they think is going on? It's very important. And the way we assess, and it is important, and I would make a suggestion that people try and get some idea of the level of control in children. Because if you say, how is your asthma? They will just say, it's fine. But you need to ask specific questions. Does he have daytime symptoms? Is he able to do his normal activities for his particular age group? Is he waking at nighttime? And how often is he using his brown inhaler? And it's the same for adults. And you can see, so ideally, with controlled asthma, there should be no daytime symptoms, no nighttime symptoms, able to do things, and rarely using the brown inhaler, less than 2 days per week. And, so that's what we like. And that's, it's a good idea to have an idea of control. And one of the things that is recommended in the Saudi guidelines is this track, which is a test. It's a little bit more of it takes there's more questions and asking about, but they fill in how often it's happening, and you can score this. You get a different score for the thing. It's in the national guidelines. It's relatively easy to do, and it's sort of the same thing. It's giving you a sort of a way of tracking their asthma control. So if you put them on treatment and you bring them back, you can look at what their track score is, or similarly, you can look at their control score. So that's a useful thing to do. And when we look at the future, this is what was important to bear this in mind. Looking at the future risk of these kids, the most important thing is if you have uncontrolled symptoms, if your asthma is not controlled, you are going to do worse than if your symptoms are controlled. So this child had one or more severe attacks during the year that involves, either admission to hospital or, of course, oral steroids. If they have a flare-up season, if their asthma is always bad in autumn, that's bad. Home exposure like tobacco smoke, etc. Socioeconomic or psychological problems going to family, or poor adherence to medications. They're just not taking their inhaled corticosteroids. And that can be a big problem in children. Parents are worried about giving inhaled corticosteroids to children, and we talk about how you deal with that. Then, what are the chances of getting fixed airway limitation if their asthma is not controlled? So if they have severe asthma, they're doing damage to their lungs, which will affect them later on in life, and if they have a history of multiple courses of bronchiolitis. And you need to look at the side effects, because there is a worry about steroid use. So children, even on medium dose steroid, will lose about 1.2 centimeters as adults. So it's very negligible, but it is important to record it. An annual weight and height check is good, and particularly on the children on the higher dose of the inhaled corticosteroids, or they're getting multiple courses of oral steroids. And often these are under specialist care also, but it's important maybe to keep an eye on it. And you need to look at, are they using their inhalers correctly? Do they know how to use them? Do they know how to protect their eyes when they're using, if they're using nebulizers, that there's a good seal of the nebulizer, the steroid is not going in causing side effects in their eyes, which we'll talk about in a second. So these are important little things to check with this child. Compliance, it's poor, and parents are often worried about the side effects of the steroids. And I often say to parents, if you're worried about side effects of steroids, then you'll always take inhaled corticosteroids, because almost 1 year of inhaled corticosteroids is the bioequivalent of a 1 week course of oral steroids. So that sometimes can put it in perspective. They're happy to let the child get bad and require steroids and risking ending up in hospital, but they don't want to give them the inhaler every day. And it makes no sense. And it needs to be explained to them that they will not get the side effects if it's done correctly. Things like action plans are important, and they're underused in children. I told one of my little kids recently, I said to the mum that I thought he needed an action plan, and he heard it, thought he said he needed an action man. I don't know if you remember this toy that's still going around apparently. So it's not an action man, it's an action plan. And this is to put parents in control of the disease. So you give them, and you try to make it individual to that patient. So you write the patient's name on, not just give them if you just give them a sheet of paper with generic things written, they won't read it. But if they see their name on it and their address, they buy into the action plan more. And then, and it explains some little things. What's the difference between a controller versus a reliever? What to advice about smoking, how to manage their asthma, little things, how to manage their peak flow, what to do if the asthma gets bad, etc. So these are action plans are worthwhile spending with patients. And here's the treatment. that so inhaled corticosteroids are still the key thing, and you get most of your benefit of inhaled corticosteroids at low doses. So the really, you know, the benefit initially is you get it up there. By upping the dose of steroids gives you a slightly, for some patients, a slightly, but most of the benefits are found when you start off with the low dose of the inhaled corticosteroids. And it is important that you explain to parents, because they will read stuff about the steroids and the turning the child into the Incredible Hulk or big muscles, or people read all sorts of things about of misconceptions about steroids. And I often would say to them that, you know, a year of inhaled corticosteroids is the bioequivalent of almost one pulse of oral steroids in regards to side effects. And that sometimes, often we've had some children who've got multiple courses of oral steroids, and yet the parents did not want them on inhaled corticosteroids because they thought we were poisoning the children, etc. You do need to monitor the side effects, particularly things like thrush, so you know that they don't get thrush in their mouth, and that can be annoying. That I usually tell them to leave the inhaler beside the toothbrush and to swish out their mouth with a little bit of water after they use the inhaler if they can. And growth, as I say, is important to monitor. So usually, particularly children on the medium or higher dose of inhaled corticosteroids, there's not too many of those, but you do need to keep an annual height and weight, if possible, of these children is important. And this is from the Society guide. This is a sort of a quick guide to where we are. So we're looking at the symptoms at the top. The daytime symptoms, activities, nocturnal. You're going to tick that. Maybe use the track score if you want it. We look at then start thinking about, is it, you sure it's asthma? What environmental things like smoking? Do they know about their education? Are they compliant, etc.? These are important. Then we're going to sort of put them in here. So we see these. So step one is still the as needed salbutamol, and you should be really using that very, very rarely, like less than twice a week. And some of the new guidelines that GINA are about to update their pediatric guidelines, I think they're going to say less than twice a month. So it should be very few patients in the step one category. So then you're into step two is the low dose inhaled corticosteroids. And that's typically the beclomethasone. We'll talk about the one, beclomethasone, 50 micrograms twice a day. If the parents can't get the inhaler into the child, or if they're really phobic or don't like the notion of inhaled corticosteroids, you can use a leukotriene modifier. We'll talk about that in a second. And then the step up, and before you step up, though, think, are they taking it? Are they using the right device? Etc. But the step up is for these kids is to double their inhaled corticosteroids, or leave on the low dose inhaled corticosteroids and add in the leukotriene, the singulaires, etc. Step four, you're not in control at this stage. You want to be maybe phoning a friend, asking, referring them on to get a specialist opinion. Often they will double the inhaled corticosteroids and leave them on the leukotriene modifier. And then up further, step five, these are very rare patients. They may need, systemic steroids, but usually this is they're attending specialist clinics. They don't worry hugely about that cohort of patients. But it is important to have idea of the stepping up and the stepping down. So if someone's well controlled, they've no symptoms, consider moving them back down. So instead of the double dose inhaled corticosteroids, moving down to the lower dose, and we explain how that is done. It's important to remember that asthma is variable, so we have to keep in mind it. And this is the typical, the beclomethasone, the CFC, the chlorofluorocarbon propellant is still the commonest inhaler. The other, fluticasone or flixotide is another one I use quite a bit. And flixotide is supposed to have less systemic side effects than beclomethasone. So flixotide 50 BD as opposed to beclomethasone 50 BD. There's a little bit of not 100% sure if that's quite as true. It was sold by the company making Flixit at the start that there was no systemic absorption. That may not be true. So the two inhalers, and there's loads of different types of inhalers, but my advice is try and get familiar with one or two that that you're comfortable with, the dosing with. And I would suggest the becamethasone and Flixitide are two easy ones to remember. And for the less than 5, the low dose is 100 micrograms. You'll see there the dose for the children, the over 5 up to 11. You'll see the dose there as well. So it's not very hard. I try to, because my brain is small, I try to remember only 2 or 3 of them to make it easy for myself. And how you get the inhaler into the children is very important. And under 5, they need a meter dose inhaler and they need a spacer device. Don't just give them an inhaler, there you go, because they cannot use it. They will not absorb it. And there's a couple of different things. This is a thing called a baby inhaler. So they put the puff in one end and the child sits over the child's face and the child would just breathe in and out. Usually about 5 or 6 tidal breaths is what it takes to get it into them. This is a useful device in the children under 2. There's also aero chambers, which are, again, a little bit more portable. And there's a number of different types of these, and that you'll be aware of that there's an orange one. You see the orange at the bottom. That's a small mask. That's for children between the age of 0 to 18 months. There's the yellow one, which I tend to use quite a bit of, and that's from children from 1 to 5. And then there's a green one from children from 5 to up to 12. So just an idea what's going on. The youth don't like using the mask and they use a little mouthpiece. And the tip with these is you put 1 puff in each time. You see people use the device where they're told to take 2 puffs, so they put 2 puffs in at once, then they breathe. That is, you would only get the equivalent of 1 dose by doing that. It has to be 1 puff at a time, 5 or 6 tidal breaths, then the next puff, not 2 at a time. You wash them, they say to wash them once a week in warm soapy water, and you let them drip dry. You don't dry them with a towel because it tends to put a static charge in them and it reduces how effective they are. These are the leukotriene modifiers. They're not, again, probably not as effective in the big studies as inhaled corticosteroids. They are useful if there's a component of rhinitis, and I say, or if they're steroid phobic or can't use an inhaler. You just be careful. You have to warn. There's a black box warning about the psychiatric effects of single air. So you need to watch the mood. The commonest side effect I find with single air is they get funny, weird dreams, and sometimes their sleep can get disturbed. But you need to say, if you're putting them on it, to just keep an eye on his mood, or if you feel he's any change and gets any odd behavior, they need to report back to you. It comes in a little granule form that can be put into yogurt, which is quite useful, easy to give them. There's a little granule. There's also a sucky sweet that they can use from about 5 upwards. So I use quite a bit of single air and get some good results with it. And I said, don't forget that it's variable. We're trying to step up and step down. So if the patient's controlled, you can reduce it. I usually reduce by the inhaled corticosteroids by about 50% if they're controlled after 3 or 6 months. Bring down the inhaled corticosteroids and see how they get on. If he's still sleepy at night and no problems, happy days. You try and reduce it further. But if he gets worse or they end up getting getting exacerbation, you need to go back up. So you're constantly trying to move up and down. And usually a guide is the dose of the inhaled corticosteroids every 3 to 6 months by about 25 to 50%, depending on what you feel clinically is appropriate. Who to refer on to, and even just have a think of yourself of what asthmatic patients you've referred to the specialists in the past year, and what was the reason. So the typical reasons are you're not sure about the diagnosis, and that's very common. You're not quite sure, or you have difficulty getting them under control. I have a very good friend of mine who's a pediatric respiratory specialist, and he says, listen, Dermot, when we see these patients, often we don't have anything much more than you have, but the only thing is we have often a bit more time and we have special nurses who can give them more time to explain about compliance. If, the very severe ones, if you're considering some of the immunotherapy or some of the MAB treatment, you might consider it. If the patient is on step 4 or higher, or the patient's had an asthma attack requiring hospitalization or 2 or more corticosteroids in the past 12 months, you consider referring them. And I put down that often, sometimes it's parental pressure. They're not quite buying into what you think, and it's nice sometimes they want to see the specialist. So sometimes that is a reason why we refer on also. I'm just going to mention, because I know, I'm sorry, quickly, I know time is pushing on. An asthma attack can be quite frightening for the parent, for the child, and particularly for the family physician who has to deal with it. There's some very good in the Saudi, in your own guideline, the SINA guidelines, there is little good algorithms which are worth being aware of. To summarize it, it's getting oxygen onto them, getting salbutamol into them, and that can be done it's not always used with a nebulizer. Now there's a move, particularly in the COVID world, where we are trying to move away from nebulizers because there is a risk of spreading COVID with nebulizers to you and your staff. So we are trying to move away from nebulizers if there's any hint of COVID and there's a little bit of worry about asymptomatic children coming in. So a spacer device, if they're less than 20 kilograms, about 10 puffs via the spacer. If they're 20 kilograms or more, up to 10 puffs each at a time, or 5 milligrams by a spacer. And some of our casualty departments are trying to get rid of their nebulizers for children, in that they're shown that the deposition rate with a spacer device is probably as good as with a nebulizer. So that is important. Also, that you give them steroids, and you can look at your guidelines. And I think it's very important, probably one of the most important, that you follow them up in the clinic within a week or two to see why it happened. Did this, and often you find that they had stopped taking their inhaler, and it's a good opportunity to bang home the importance of compliance. And if you can say, listen, this is dangerous. Children die of asthma attacks, so it's important that you give them, you find out why it happened, ensure that they're compliant, that they're using their device correctly, that they're using their spacer. Give them some time maybe with the nurse to show them there's a number of videos online where they can look at themselves, which is we use quite a bit, to give them how to use the device. So that is my final slide. So thank you very much, everyone, for listening, and I'm happy to answer any questions you may have.
Thank you very much, Dr. Dermot, for the nice and practical speech. There is many questions were posted. There are many questions that were posted in the chat. So, but I would just highlight one information that you were told us, that we face it a lot in the clinic when the parents trying to avoid using steroids, especially the inhaled steroids. So when you told, say, 1 year of inhaled steroid, it's equal 1 week of oral steroid. So maybe it's a way to convince them that there's no danger if they use it for a month. And
exactly, Dr. Nada. I think sometimes parents are quite surprised when they hear that, and it's a really good way of trying to, because they don't, particularly when one of the problems with asthma is that the children, they are well, they're running around. Why does he need this medication? He's perfectly fine. We don't need to give him any medication. And it's often very hard, and it's hard for us as well as parents to give our children something when they seem well. But so you need to the risk though of them exactly ending up with or getting multiple, and sometimes these children will get multiple courses of oral steroids, and that is much more damaging to them, to their health, to their growth, to their bones, than the inhaled corticosteroids. And particularly when you're using inhaled corticosteroids with the spacer device, they don't get and wash out their mouth. The systemic absorption is very, very small.
Thank you, Dr. Dermot. First question, there was a question about what about the post-viral COVID, the post-viral cough? And there is any evidence to support its management as we are managing bronchial asthma or? So it's a very good question. And there is it's very difficult. The bottom line is we should do nothing for them. There is no real evidence that anything works for them, and it can be frustrating for parents because it can go on for quite a while. But I think sometimes if parents, you explain to them, this is a virus, the lungs have to recover. Up to now, we've been giving these kids all sorts of things, antibiotics, and there is good evidence now that antibiotics might be keeping the cough going. There's a lot, and even children who get more than 2 courses of a broad spectrum antibiotic before the age of 3 increase quite dramatically their risk of asthma. So what is important is to say this is a viral cough. The kids are well. It's annoying. It's sort of, they're not sleeping. It can be difficult, but not to be given. You can maybe, if you think there's an asthma component, to try a salbutamol, but not to give them inhaled corticosteroids. And probably the big evidence is that nothing makes a big difference. We've tried all sorts of things: hypertonic saline, nebulized, budesonide, all sorts of things, and it hasn't made a difference. Okay, thank you. There is another question. Is about they are asking about the role of inhaler steroids in acute bronchial asthma.
Yeah, it's a good question, but it takes about an inhaled corticosteroids. The dose is not high enough, so in the acute situation, it will not help. They need oral steroids if they're acutely unwell, and usually for about 3 to 5 days, up to about 20 milligrams per day. So it gives them they get a much quicker response. The response is too slow with the inhaled corticosteroids, but with oral steroids, they get within about 2 hours they will get relief. It's too slow with the inhaled corticosteroids, so there's probably no role for inhaled corticosteroids in the acute attack. Now, what is interesting is, if the children start to slightly deteriorate, so if you see they're starting to get their child with asthma, what we can sometimes do is we can quadruple up the dose. So instead of taking 1 puff of the beclomethasone twice a day, if you take 4 puffs twice a day, that's what we do in adults. So this is what we give them, self-management. We tell them to quadruple your inhaled corticosteroids early on the attack. They've done a number of trials of this, and it hasn't been very successful in children. So it's not really recommended. When they've done this, in theory it should work, but in practice it doesn't seem to work. And they've almost, so there are some specialists that feel that it does help, but when they've done the trials and the studies on this, doubling or quadrupling inhaled corticosteroids early in the attack has not really helped them.
Okay, so in bronchial asthma, acute bronchial asthma exacerbation, better to use a systemic steroid.
Yeah, and I tend to use prednisone, which is dissolvable. They're little red tablets, and they dissolve in water, and they're easy to get into the children. Sometimes if the child is unwell with asthma, sometimes it can be maybe difficult to get medication into them.
Yes, it's, there is another question also about how can practical or key points that can help the residents to differentiate diagnosis of bronchiolitis and versus bronchial asthma attack.
So
children?
Yeah, so and that's another very good question. If you look at my earlier slides, and I think I'll ask Victoria to share them. So this is where we have to be detectives. This is where we need to start thinking, well, you know, is there a family history of asthma? Is this a recurrent episode? Is it just a once-off? Is it recurrent? Is there atopic features? So there is no way of determining it because they will both often present the same way. But what you need to do is look at the pattern of illness. So if this is the third time back with this same bronchiolitis, it may be asthma. Now, usually bronchiolitis are associated with, they get runny noses or viral type. They usually have viral illness. But asthma tends to present with, when they don't have that, when they don't have the runny nose or the slight URTI, and that's when you have to be more suspicious. But there is no real way of differentiating it, but you need to be clinically suspicious of it.
Yes, and investigate family history, other atopic presentation, and so on.
Exactly.
Thank you, Doctor. There is also a question about what is the daily dose of steroid in asthma, and how frequent children, if they, for the maintenance.
So I have that in one slide earlier. You can see, so for this age group, for the young preschoolers, the under 5, it's beclomethasone or fluticasone, 100 micrograms total. So that's 50 micrograms in the morning, 50 micrograms in the evening time. And I did a list. So over 5, you'll see I've done the list of all the different doses of and what's really important is to remember is that most children should be able to control on low dose inhaled. That's where you get most benefit, is with the low dose inhaled corticosteroids. So you shouldn't be needing to give these big, if you're giving big doses of inhaled corticosteroids to children, you sort of want to just check that your diagnosis is right and maybe look at getting a specialist opinion. So they should be able to control them on 50 micrograms of beclomethasone, which is cheap and cheerful, and it's easy to use, and via a spacer device. So that's the dose that I recommend.
Doctor, there is a repeated question about an acute exacerbation in children regarding the control. They are asking about the nebulizer. Is it equal the oral, or is it equal the MDI? What do you think?
Yes, so this is a bit of a, so now we are trying to move away from the nebulizers because there's a perception, and sometimes parents have this perception, oh, he went on the nebulizer machine, it's fantastic, you know, it's because they see the smoke and the fume, and it's like theater, it's like dry ice magic. But here's the problem with the nebulizer. One is that parents start to believe that they have to go to the hospital for the machine, for the nebulizer. Secondly, most of the nebulizer gets nebulized into the atmosphere. It doesn't go into the lungs where you want it. So only about 5 to 7% of the drug goes into the alveoli when you use a nebulizer. So, you know, and it's, you know, it creates a dependence on it. Whereas with this, and some of the casualty departments are trying to move away from the nebulizers because you get as good drug deposition with a spacer device. Now, there's no smoke and fume, and sometimes parents want the drama, and now in the COVID world, we need to be careful about using nebulizers because there is a risk of aerosolizing the virus into the atmosphere and infecting you, your nurse, other patients that might be around. So there's a big move against nebulizers now in our hospitals and in our community. And what you're trying to teach parents that they can manage this asthma themselves without a machine.
Okay, so in general, they are using Pulmicort, budesonide, or adding other elements like Atrovent to the nebulizer. The benefits would be
yeah. So Yeah, so Pulmicort is another steroid. I don't use an awful lot of it. It's in a dry. So for the young children, it only comes in a dry powder device, so they can't really use it in this age group. It is useful for some of the older kids. You'll see it, and you can use nebulized budesonide. Atrovent for more severe attacks, and if you look at their guidelines, in the first hour there is some role for ipratropium in very severe. You have to grade the attacks into mild, moderate, and severe. And in the moderate to severe, there is a role for Atrovent in the first hour in the nebulizer. Yeah, but they are rare. I can't remember the last time I used it. It's not a common drug I use very much.
Because we are, especially in the pediatric departments, they're using nebulizer and using Atrovent and using. That's why maybe our residents, they're asking a lot about the nebulizer, because the practice that they see and the guidelines. So they just want to make sure that.
Yeah. So for the moderate to severe attacks, that they're probably the one that are ending up in hospital. Atrovent is useful only for the first hour, not for continuous use, funny enough. So and if you have a little look at the Saudi Thoracic Society guidelines, they have quite, and it's worth printing. It's printed out. It's worth printing that out just for if you're dealing with acute attacks. It tells you exactly what to do, and it's quite clear. But they recommend Atrovent in the first hour, but not the benefit after that is not very clear.
Thank you so much. There is a question about the role of the peak flow meter in diagnosing asthma in children. Peak flow meter.
Yeah, again, well, for older children, it's really useful. But I can't. I said I just try to concentrate on the very young children. You can't get an under 5 to use a peak flow meter. They can't use them. So for older children, usually from about 8 onwards, it's a very useful tool. And why it's useful is that it can be used as an early warning system. So if they monitor every morning, they see their peak flow at 200 or whatever it is, and if they see it dropping down to 160 or 150, they will sometimes drop their peak flow before they get symptoms. So it can be useful for parents to be careful to maybe up the inhaler a little bit for a few days beforehand. So for slightly older children, peak flow meters are useful. For younger children, this age group, they're too young.
Yeah, too young. Yes, exactly. Okay, what about the effect of inhaled corticosteroid on bone growth?
It does. It does have an effect, and we know that that growth there is a slightly increased risk of osteoporosis later on in life and overall growth. So the growth with medium dose steroids, they lose about 1.2 centimeters as an adult. But what's not quite sure, no one's really studied it. So that asthma itself may, if you're asthmatic and you're sickly and you're in hospital, that might be a factor. So although it may affect bone growth, it probably affects bone growth less than uncontrolled asthma. So I think that's important to bear in mind but for children who are on high dose inhaled corticosteroids, you need to watch their growth needs to be monitored. So you need put them on a chart to keep an eye on it, that they're not falling off it. And if they are falling off it, you need specialist help with that.
Can it reach the similar effect of oral steroid on the bone?
Yeah, it can. It absolutely can, because they're on them for a long period of time. But it's more for women than in men, and it's I think probably if you have poorly controlled asthma and you're not doing exercise, and that probably has a big effect on your bone health also. So I think you have to weigh it up that it might have some effect. It's small. But I think it's better to have your children well and running around and playing sport, and active and sleeping at night time and able to go to school, rather than worrying about small little risks of osteoporosis when they're 70. I think we need to put it in perspective. I'm afraid, Dr. Nada, I have to go. I'm afraid. Apologies. I just have to collect children, so I'm afraid I'm going to have to leave you. But Victoria and Tony have my contact, so if I can be of any help, if there's any questions that you'd like me to follow up, and I'd be more than happy to help out with that.
Thank you, Dr. Dermot. We already finished our question. If you would like to give like a take-home message to our residents before you leave, we will be very grateful.
So the take-home message is, when you're looking at patients with asthma, make sure they're taking inhaled corticosteroids and make sure they know how to use the device. Simple.
Thank you so much, Doctor. Thank you.
Thank you, Dermot. Lots of lovely comments coming in from all in Saudi.
Thanks,
so
Dermot, yeah.
Thank you very much. All right.
Very welcome.
Okay. Bye-bye, everyone.
Thank you.
Thanks,
Hope
Dermot.
it's sunny in Saudi. Enjoy the sunshine.
Yeah.
Think of us here in the rain and the misery. It's awful.
Yeah.
Thanks.
End of some sunshine. Yeah. Okay. Thanks, everyone.
Thanks, everyone.
Thanks,
Bye.
Tony.
Bye.
Thanks, Vicky. Bye.
Thanks, Vicky. Yeah, bye, everyone.
Thanks, everybody. All right, bye.
Bye.
Somebody says they missed the rain. Come here.
Here, exactly. Yeah.
Yeah, we got to get those placements back and get the rain for you.
Yeah, exactly.
All right. See you guys. Bye-bye.
Bye,
Yeah,
bye.
bye.
See you, Molly. Bye.